A white bottle, a barcode, a copay that refuses to match the number on the package. In the United States, a single prescription can travel under 4 different prices: a manufacturer list price, a pharmacy reimbursement written into a network contract, a billed amount sent to a health plan, a patient copay or coinsurance that follows a formulary tier rather than the net dollars that actually changed hands. 4 prices, 1 pill. Health plans hire pharmacy benefit managers to occupy that gap. The assignment, on paper, is cost control. Process millions of claims, assemble pharmacy networks, negotiate with drug makers, rank medicines on a formulary, stop the drug benefit from becoming an open tap. The hire looks rational. The catalog of pills is vast. Brand drugs, generics, specialty infusions, and 90-day mail-order fills do not administer themselves. An insurer that tried to bargain every molecule with every pharmacy would drown in paper. Then the contradiction steps forward.
The same intermediaries hired to control prescription costs can also earn money from rebates that never print on the receipt, from the spread between what a plan is charged and what a pharmacy is paid, and from pharmacies owned inside the same corporate family that designed the rules. The cost control function does not disappear. It shares the room with another set of incentives. This is not a fable about one villain with a hidden lever. It is a map of a payment chain. Pharmacy benefit managers stand between drug makers, insurers, pharmacies, and patients. From that position, they can influence which medicines millions of Americans receive, which counter is allowed to fill them, and how the cost is split among 4 parties who never see the same invoice. Listen, wait at the pickup window. The specialist's tools include volume, opacity, and integration. Those tools can lower a net price. They can also relocate the margin. The chain begins at hiring. It does not end there. Pharmacy benefit managers did not enter American healthcare as philosophers of price. They entered as clerks with computers. In the later decades of the 20th century, employer coverage and managed care plans begin treating outpatient drugs as a prepaid benefit rather than a cash sale at a corner register. The shift creates a problem of volume. A claim must be checked for eligibility, for refill timing, for a molecule the plan actually covers. A traveler must be able to fill a prescription in another city without leaving the network. Someone has to maintain the list of what is paid, what is rejected, and what requires a doctor to explain. Insurers could have built that machinery inside their own walls. Many choose a vendor. The vendor's first advantage is not wisdom, it is speed. Adjudicate in seconds. Attach a pharmacy to a contract. Move a file of transactions overnight. In that era, cost control often means a simpler thing than it will later mean. Do not pay for a drug the plan excluded, and route volume toward pharmacies that accepted the rate. That is the historical blind spot. Patients meet a copay. They do not meet the claims tape.
Then the medicines themselves change character. Brand manufacturers post list prices that large buyers rarely intend to pay in full. In 1990, federal Medicaid statute hardens a public rebate into law, teaching the wider market a dialect of discounts that arrive after the sale. Commercial purchasers learn a cousin of that dialect. A rebate is not a lower number printed on the bottle. It is a later payment, flowing from a manufacturer toward the entities that can promise access to insured patients. Access needs a steering wheel. The formulary becomes that wheel. Preferred products on a lower tier. Non-preferred products behind a higher patient charge or a prior authorization maze. Generic products in a cheaper lane. The administrator of the menu does not invent the molecule. It invents the sequence of friction. Which drug is easy? Which drug requires a phone tree? Which drug is simply not covered? Health plans hire this function because they need a counterparty that can play bad cop with manufacturers and pharmacies at a scale no local benefits office can match. Years later, the U.S. Government Accountability Office will describe the work without romance.
Pharmacy benefit managers administer prescription drug benefits for plans. They negotiate rebates, they affect drug pricing, they use pharmacy reimbursement arrangements. Among those arrangements sits a practice that state governments will spend a long time trying to drag into daylight: spread pricing. The intermediary reimburses a pharmacy one figure and charges the health plan another. The difference can remain in the middle. The plan may treat it as a bundled rate. The pharmacy may treat it as a haircut. The patient may never see it because the register follows a tier. A second transformation arrives through Medicare. Congress passes the Medicare Prescription Drug Improvement and Modernization Act in 2003. Part D coverage begins in 2006. Older Americans in large numbers now carry a structured outpatient drug benefit run through private plans. Those plans need national networks, national formularies, and rebate negotiation at a scale that makes the middle seat into infrastructure rather than a back-office convenience. Watch a small pharmacy in that new world. The owner still counts pills. The owner also studies reimbursement files that no customer ever reads.
A chain with mail order volume studies the same files with more leverage. A manufacturer studies placement, not merely wholesale invoices. A patient studies a copay that can jump when a drug changes tier, even if the chemistry did not change. The original reason for the hire never fully dies. Claims still must clear. Networks still must exist. Rebates still can reduce what a plan spends relative to list price. The blind spot is assuming a vendor hired to restrain net cost has one ledger, and that every tool that helps a plan's invoice also helps the patient or pharmacy. The pickup line paradox now has a history. Plans hired a claims engine. The engine grew a gate. The clerk learned to collect a toll without ceasing to process the claim. A health plan is not shopping for a bottle. It is shopping for a year of drug benefit that will not explode the premium. Its fear is trend. The plan hires a pharmacy benefit manager because it needs a counterparty who already sits across the table from those manufacturers and already owns a machine that can say yes or no at the pharmacy switch in real time. The plan's motive is net cost and administration. Pass-through of rebates can be written into a contract. Retention of rebates can also be written into a contract. Spread can be banned in a state statute and still leave other margins. The plan is a principal. The PBM is an agent. The quality of that agency depends on the contract, the audit rights, and whether the agent has a second business poised for the same prescription to travel through its own pharmacy. A manufacturer lives on a different clock. Research is sunk. A patent clock is running. List price is a public number that sets the ceiling from which discounts are carved. If a large intermediary can move millions of insured lives toward a preferred product, the manufacturer can offer a rebate for placement. The rebate can grow with the list. A higher list and a higher rebate can leave the plan's net negotiated, while a patient's charge still tracks a sticker or a tier. It is a bargaining pair. List and rebate travel together. The intermediary who controls the formulary becomes the audience for that pair. An independent pharmacy lives on reimbursement minus acquisition cost and time. Its life or death decision is whether to remain in a network that sends it patients, but pays a rate that may sit below the economics of keeping the lights on. Walk away, and the patients may be steered elsewhere. Stay, and the margin may thin until the store is a waiting room with a door. A mail order or specialty pharmacy owned by the same family as the PBM lives on a different decision. It pursues the fill. The formulary, the network design, and the member communications can make the owned pharmacy the path of least resistance. Refills route inward. Specialty products that never touch a neighborhood counter. Volume that stays inside the family does not have to be shared with a rival dispenser. The patient is the character with the least paperwork and the most urgency. A denied fill. A switch to a preferred product. A copay that ignores a rebate the patient will never see. The patient does not attend the rebate meeting. The patient attends the pickup window. The PBM collects several possible wages: a per-claim fee, a share of rebates, a spread where the contract still allows it, a margin at an owned pharmacy. None of these wages requires a cartoon villain. Each wage is a rational line on a statement. The incentive is positional. The firm is paid for occupying the middle, and the middle gains value when list prices can fund rebates, when formularies can steer, and when the fill can be captured. And then a formulary vote happens. The room is windowless. The votes stay quiet. Markets do not. July 2024. The Federal Trade Commission releases an interim staff report on prescription drug middlemen. The language is not a courtroom verdict. It is staff analysis.
It is qualified. It talks about incentives and potential effects. It still lands like stone. The factual nucleus is blunt enough to hold. Staff documents that the 6 largest U.S. pharmacy benefit managers handled more than 90% of prescriptions in 2023. Concentration in that sentence is not a metaphor. It is a share of the nation's fills. Around that share, the report describes a structure: vertical integration, formulary influence, effects on pharmacies. The intermediary is no longer only a hired calculator. It is a clustered set of firms that can administer a benefit, negotiate with a manufacturer, steer a fill, and, in related corporate form, dispense the drug. Do not overhear that as a finding that every contract raises every patient's price. It does not. The staff's own caution is part of the record. Incentives can pull more than one direction. A rebate passed through to a plan can lower net spending. A formulary can increase generic use. A network can produce discounts.
The same tools can also reward a high list, a retained rebate, a spread, or a fill captured by an affiliated pharmacy. Potential is not proof in every file. That qualification is the wound's clean edge. The dirty edge is power plus opacity. On one side stands the cost control function that health plans purchased and that state houses already felt the need to police. The Government Accountability Office's work on selected states' regulation of pharmacy benefit managers is not a manifesto. It is a record that legislatures have been writing rules around rebate opacity, pharmacy reimbursement, and the middle firm's conduct. Plans still need claims policing. States still watch reimbursement arrangements. Statutes appear because the hire has consequences large enough for a capital. On the other side stands the staff's concentration map. If more than 9 in 10 prescriptions run through 6 firms, manufacturers do not face a cloud of small buyers. They face a handful of gates. Pharmacies do not face a cloud of network designers. They face a handful of contracts. Patients do not face a cloud of formulary philosophers. They face the menu those gates publish.
Watch a rebate negotiation in this climate. A manufacturer brings a product. A competitor sits one molecule away. The manager controls a preferred tier that can shift millions of fills. The bid is not only make it cheap, the bid can be make the rebate large. A large rebate is easier to fund from a large list. The plan may see a net. The patient, if cost sharing still follows list or a brand tier, may not. The affiliated pharmacy, if it dispenses the winner, may see volume. The losing manufacturer may see a wall. Watch a pharmacy reimbursement file in the same climate. The independent owner counts pills and then studies a rate that may sit below acquisition plus labor. Where a state has not closed the spread, the gap remains. Even where spread is restricted, other terms can set the effective rate: network fees, reconciling adjustments, delayed true-ups. The staff report's pharmacy effects live here, in the daily arithmetic of remaining in-network or surrendering the fill to mail order. Watch vertical integration as a morning on a campus, not a conspiracy in a basement. Mail order facilities hum. Specialty pharmacies handle drugs that cost more than a used car.
A member message suggests a 90-day refill that never visits Main Street. Formulary staff, an insurer affiliate if there is one, and the dispenser can align without a coded note. Alignment is the point of common ownership. Alignment is also the conflict. The climax is not an explosion. It is a recognition. The intermediary hired to control costs now sits in a concentrated, integrated position where controlling costs and capturing value can look, on a spreadsheet, like cousins. Barriers break in sequence. First, claims processing scale becomes a barrier to entry for anyone who would replace the specialist. Second, rebate relationships become a barrier because manufacturers need the gate. Third, owned pharmacies become a barrier because the fill can be redirected inward. Fourth, opacity becomes a barrier because a patient, a plan sponsor without audit muscle, and even a state legislator may see only one of the numbers attached to a pill. Dominoes. A high list supports a high rebate. A high rebate supports preferred placement. Preferred placement supports volume. Volume supports the argument that the manager is delivering savings off list.
List, meanwhile, can remain the ghost that haunts coinsurance, launch headlines, and the sticker a cash customer faces outside the insured path. States push back with statutes. Some demand spread reporting. Some try to define what a manager owes a pharmacy. Some try to force rebate language into the open. The Accountability Office's selected state work is a catalog of that push, not a claim that the push has equalized power. The Commission's staff push is different in register. It is national. It names concentration. It worries about conflicts that vertical structure can create. It remains interim. Staff is not the full Commission speaking with a final order. Analysis is not a finding of liability in every contract. Qualified language is not a dare to pretend otherwise. The asterisk does not freeze a single fill. Prescriptions still run. 6 large managers still sit on most of them. Independent pharmacies still calculate whether the next generic is a service or a loss. Manufacturers still bid rebates. Plans still hire the middle. Patients still meet a number that may be a copay, a deductible, a surprise denial, or a mail-order substitution. Cost control is not imaginary.
Concentration is not imaginary. Conflict concern is not a verdict of theft. The staff report does not convert every rebate into a theft. The state statutes do not convert every manager into a public utility. The wound is the dual use of the same tools. The break and the toll can be the same contract clause, read by 2 different parties. There is an older problem in economics that does not need a new name. A principal hires an agent. The agent knows the terrain. The principal needs a result, a drug benefit that can be priced into a premium and survived by a workforce or a public program. The agent is paid. Payment has to come from somewhere. If the payment is a flat fee for claims, the agent is a processor. If the payment is a share of a discount off a list the agent helped keep high enough to discount, the agent is something else. If the payment is a spread the patient never sees, the agent is something else again. If the payment is profit at a pharmacy the agent can steer, the agent is on both sides of a counter the principal may never visit. The weirdness is legal and ordinary. List price becomes a stage set. Net price becomes a private conversation. The patient's share becomes a tier. The pharmacy's share becomes a contract rate. 4 conversations, and the specialist fluent in all of them can be useful, and can be conflicted, and can be both in the same week without a single clause being imaginary. Cost control in this design is a comparison to a number that was never the street price.
Savings off list can be real on a plan's ledger and still leave a patient facing a launch price coinsurance, a cash customer facing a sticker, a pharmacy facing a reimbursement that does not track the rebate, a competitor drug facing a wall. None of those statements requires a claim that every contract injures every patient. They require only that the ledgers are allowed to diverge. The larger principle belongs to any market where the buyer of record is not the person who swallows the good, and where the discount is paid as a side transfer rather than a lower posted price. Insurance already separates the patient from the payer. Rebate architecture separates the posted price from the net transfer. Vertical dispensing then separates the network's choice from an independent counter. Stack the 3 separations, and a small group of intermediaries can influence medicines, pharmacies, and the distribution of cost without matching the cartoon of a single hand on a single switch. What remains after the reports and the statutes is a taste, not a verdict, a pickup window, a box on a porch.
A benefits consultant sliding a spreadsheet of discounts that never quite explain why the bottle still feels expensive. A rural store doing the arithmetic at night. A manufacturer bidding a rebate against a rival's rebate, as if the patient were a territory. This is not a sermon about greed. It is a map of incentives that become rational only after the split is named. The mechanism is the split. Hire a specialist to manage the split, and you may receive management. You may also receive a firm that lives on the split. The fluorescent lights over a counter do not display a rebate. They display a copay. The difference is the entire documentary. A contract can be both a brake pedal and a cash register. The paper does not choose which one you notice. Read the clause twice over. If the specialist is paid from the fog between what a factory posts, what a plan nets, what a pharmacy banks, and what a patient hands over, who exactly is the client?